Welcome everyone. Today we embark on an exploration into the complexities of osteoarthritis, OA, a prevalent degenerative joint disease impacting millions worldwide. Unlike the inflammatory nature of rheumatoid arthritis, RA, OA presents with its own distinct clinical and pathological features. Through this in-depth analysis, we aim to equip medical professionals and students alike with a comprehensive understanding of OA, unraveling its intricate nature and distinguishing attributes. Let's dive in. Let's explore the asymmetrical distribution of affected joints in osteoarthritis, OA, compared to rheumatoid arthritis, RA. In OA, joints are typically affected in an asymmetrical pattern, especially noticeable in weight-bearing joints like the knees and hips. This asymmetry often results in one side being more affected than the other, contributing to the unique presentation of OA. In contrast, RA is characterized by a symmetrical distribution of joint involvement, where the same joints on both sides of the body are often affected. This symmetrical pattern is a hallmark of the inflammatory nature of RA and serves as a key differentiator from OA. It's important to recognize that while OA and RA have distinct distribution patterns, other forms of arthritis like seronegative spondyloarthropathies, gout, and pseudogout can also present with asymmetrical joint involvement. Understanding these differences is essential for accurate diagnosis and tailored management strategies in clinical practice. Let's delve into the non-inflammatory nature of osteoarthritis and its contrast with rheumatoid arthritis. In osteoarthritis, the pathological processes primarily revolve around bone remodeling and cartilage degeneration, distinct from the inflammatory joint destruction observed in rheumatoid arthritis. This lack of inflammation in OA is evident through the absence of systemic features and the typically normal levels of inflammatory markers like erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP. In contrast, rheumatoid arthritis is characterized by a robust inflammatory response leading to bone erosion and cartilage destruction. This inflammatory process is often accompanied by elevated levels of inflammatory markers, aiding in the differentiation between RA and OA. Although both conditions impact cartilage and bone structures, their underlying pathological mechanisms are markedly different. In OA, the focus is on bone remodeling and cartilage degeneration, while in RA, the primary driver is the destructive inflammatory process. Understanding these distinctions is crucial for accurate diagnosis and tailored treatment strategies for patients presenting with joint-related symptoms. Let's explore the characteristic features of osteoarthritis, particularly focusing on bony growths and joint space narrowing. One hallmark feature of OA is the development of osteophytes, which are bony growths that form at the edges of affected joints. Unlike the bone erosion seen in rheumatoid arthritis, these osteophytes result from osteoblastic activity and contribute to the characteristic degenerative joint appearance in OA. Furthermore, they can lead to the narrowing of joint spaces, impacting joint function and mobility over time. As OA progresses, narrowing of joint spaces becomes increasingly evident on radiographic imaging. This narrowing is primarily due to the loss of articular cartilage, which compromises joint function and mobility. It's crucial to differentiate this joint space narrowing from the osteopenia observed in other conditions, as they represent distinct pathological processes. In the fingers, the distal interphalangeal DIP joint is commonly affected in OA. Here, the development of bony growths, known as Heberden's nodes, is characteristic and aids in clinical diagnosis. These unique pathological features of OA, including bony growths and joint space narrowing, have significant implications for therapeutic management. Treatments often target addressing underlying bone and cartilage changes rather than the inflammatory processes seen in other forms of arthritis, highlighting the importance of tailored approaches in OA management. Understanding these distinct features is essential for accurate diagnosis and effective management of patients with osteoarthritis. Now let's outline a stepwise approach to managing osteoarthritis based on the severity of symptoms. For patients with mild OA, initial treatment often involves the use of acetaminophen. This medication can provide effective pain relief without the potential adverse effects commonly associated with nonsteroidal anti-inflammatory drugs, NSAIDs. As symptoms progress to a moderate level, the treatment approach may shift to NSAIDs, either orally or topically. This may be particularly beneficial for individuals with an underlying risk of gastrointestinal side effects. In cases of severe OA, a more aggressive approach may be warranted. This may involve the combination of NSAIDs and steroid injections directly into the affected joint, providing targeted relief and helping manage the advanced stages of the disease. When conservative treatments have been exhausted and the patient continues to experience significant pain and functional impairment, surgical intervention may be considered. Joint replacement surgery, particularly for severe OA affecting the knees and hips, can offer long-term relief and improve quality of life. This stepwise approach ensures that treatment strategies are tailored to the individual's needs and the severity of their osteoarthritis symptoms, ultimately optimizing outcomes and enhancing patient well-being. Let's discuss the ineffectiveness of disease-modifying anti-rheumatic drugs, DMARDs, in the management of osteoarthritis, in contrast to rheumatoid arthritis, RA, where DMARDs play a central role in treatment. There is no established role for these medications in managing OA. This is because the underlying pathological mechanisms in OA differ fundamentally from the inflammatory processes targeted by DMARDs. As a result, DMARDs are ineffective in addressing the degenerative joint changes characteristic of OA. While supplemental therapies like glucosamine and chondroitin have been explored for OA management, studies evaluating their long-term efficacy have yielded inconclusive results. This uncertainty leaves their role in OA treatment ambiguous, and further research is needed to elucidate their potential benefits. Understanding the limitations of DMARDs and exploring alternative therapies underscores the importance of tailoring treatment strategies to the unique pathophysiology of OA, ultimately optimizing outcomes for patients with this prevalent joint condition. When conservative treatments have been exhausted and the patient continues to experience significant pain and functional impairment, surgical intervention may be considered. Joint replacement surgery, particularly for severe OA affecting the knees and hips, can offer long-term relief and improve quality of life. This stepwise approach ensures that treatment strategies are tailored to the individual's needs and the severity of their osteoarthritis symptoms, ultimately optimizing outcomes and enhancing patient well-being. Let's compare and contrast osteoarthritis, OA, and rheumatoid arthritis, RA, to gain a comprehensive understanding of these two prevalent forms of arthritis. Osteoarthritis, the most common form of arthritis, primarily affects weight-bearing joints and is a significant cause of disability in the elderly population. It's characterized by an asymmetrical distribution of joint involvement, a non-inflammatory pathogenesis, and the formation of bony growths known as osteophytes. In contrast, rheumatoid arthritis is an autoimmune inflammatory condition that typically presents with a symmetrical distribution of joint involvement. The underlying pathological process in RA involves joint erosion and destruction driven by the body's immune system attacking the synovial tissues. Beyond differences in joint distribution and nature, OA and RA also vary in their underlying pathophysiology, systemic manifestations, and therapeutic approaches. Understanding these distinct characteristics is essential for accurate diagnosis and effective management of these conditions. By recognizing the unique features of OA and RA, healthcare professionals can tailor treatment strategies to address the specific needs of each patient, ultimately improving outcomes and enhancing quality of life for individuals living with arthritis. In conclusion, it's essential to embrace the unique aspects of osteoarthritis, OA, to improve diagnosis and management. The asymmetrical distribution of joint involvement in OA, contrasting with the symmetrical presentation of rheumatoid arthritis, RA, serves as a key distinguishing feature for clinical diagnosis and management of this degenerative joint condition. The non-inflammatory nature of OA, characterized by bone remodeling and cartilage degeneration, differs significantly from the inflammatory joint destruction seen in RA. This distinction has important implications for therapeutic approaches, highlighting the limited utility of disease-modifying antiarrhythmic drugs, DMARDs, in OA management. Radiographic findings such as the development of osteophytes and narrowing of joint spaces are hallmark features of OA, reflecting distinct pathological processes not observed in RA, including bone erosion and inflammation. By recognizing and understanding these unique aspects of OA, healthcare professionals can tailor treatment strategies to effectively address the needs of patients with this prevalent joint condition, ultimately improving outcomes and enhancing quality of life.